our distinguished speaker, Dr. Haris Ali. Dr. Ali is Associate Professor in the Division of Leukemia, Department of Hematology and Hematopoietic Stem Cell Transplant at City of Hope. He also served as a section leader of the Myeloproliferative Neoplasm Program. Dr. Ali earned his medical degree from Rawalpindi Medical College in Pakistan. He completed his internal medicine residency at Lomba Linda University Medical Center, where he served as the chief resident and later joined as a faculty as an instructor and an assistant professor. He then pursued a fellowship in hematology and oncology at UT Southwestern Medical Center, followed by a specialized fellowship in hematopoietic stem cell transplant at City of Hope, where he now serves as faculty. His research focused on myeloproliferative neoplasms, including myelofibrosis, polycythemia vera, essential thrombocythemia, CML, and chronic myelomonocytic leukemia. He is actively involved in the development of novel therapies, including targeted agents and immunotherapies, as well as strategies for the prevention and treatment of graft versus host disease. We are truly honored to have him here today. Please join me in welcoming Dr. Haris Ali.
Thank you, Dr. Shah, for the kind introduction. Assalamu alaikum, everyone. The topic of my talk today is management strategies in myelofibrosis. This is just an overview of the presentation. I'll start off with the MPN introduction and classification. Subsequently, we'll go over myelofibrosis, introduction, diagnostic criteria, histology, pathogenetic feature, pathogenesis, presenting symptom, risk stratification, and risk and symptoms-based management. So I'd like to start with the history of the disease. So the first case of MPN was actually described by Dr. Gustav Huck, who was a German surgeon, who actually described two cases of what he called at that time was splenic medullary leukemia or pure splenic leukemia. These were the patient that presented with leukocytosis and a massive splenomegaly. Most likely, these patients had a CML. Subsequently, Dr. Louis Vasquez in 1892, a French physician, described a patient of polycythemia vera, where a man presented with symptoms of a headache and a ruddy face, turned out to have a vascular congestion, cyanosis, splenomegaly, and marked erythrocytosis. In 1907, Dr. Hermann Essmann, he coined the term osteosclerosis in patients with primary myelofibrosis when he saw new bone formation. And subsequently, throughout the 20th century, further histological features of MPN were described, like extramedullary hematopoiesis, reticulum fibrosis, and peripheral blood leukoerythroblastosis. But it was not till 1951 when Dr. William Demeshek, who was at Tufts University in Massachusetts, he described and actually grouped all these conditions, CML, primary myelofibrosis, PV, and ET together as myeloproliferative syndrome. He actually wrote a small paper on this where he described his findings very eloquently. He said that with accumulating experience, it becomes more and more evident that the bone marrow cells, which are erythroblasts, granulocyte, megakaryocytes, often proliferate in mass or as a unit rather than as a single element. And it is possible that these various conditions, myeloproliferative disorder, are all somewhat variable manifestation of proliferative activity of the bone marrow cells, perhaps due to hitherto undiscovered stimulus. So, myeloproliferative neoplasm is a separate category of hematologic neoplasm in WHO as well as ICC. And they are phenotypically diverse group that are stem cell derived clonal disorder characterized initially by slow and progressive myeloid proliferation. And they're classified into two different types, BCR-ABL positive, which is CML, and the BCR-ABL negative, which in classical MPN include PV, ET, and primary myelofibrosis. And the characteristic features they have, most of them have driver mutation within the stem cells and the myeloid progenitor cells, which leads to cytokine independent or cytokine hypersensitive proliferative signal, leading to overproduction of myeloid cells. They share several lab and clinical features, including cytosis, constitutional symptom, organomegaly due to extramedullary hematopoiesis, progressive myelofibrosis, thrombotic complication, and the risk of developing into AML and bone marrow failure. It used to be we had before 2022 we only had WHO classification, but now we have two different classification. I mean, thankfully in MPN there's not too much difference, except that in ICC divides primary myelofibrosis into two different type: early prefibrotic myelofibrosis or overt primary myelofibrosis. Also in WHO classification, there's an additional category of disease called juvenile myelomonocytic leukemia, which is seen typically in the younger population. So myelofibrosis it's a relatively rare disease. In the US, we see about 0.2 to 0.5 cases per 100,000. And median age of diagnosis is 65. And subtypes are primary or post-ET, post-PV. And in the ICC classification, we have a prefibrotic myelofibrosis as well as overt myelofibrosis. The diagnostic criteria, this is by the ICC. There are three major criteria. It requires presence of three major criteria or at least one minor criteria. And the major criteria are megakaryocytic abnormalities, the presence of driver mutation or any other clonal abnormality, and not meeting any criteria of any other myeloid neoplasm. Minor criteria could be anemia, leukocytosis, splenomegaly, elevated LDH. Here's the difference between the overt myelofibrosis versus the prefibrotic primary myelofibrosis. That in overt myelofibrosis, you see a much more denser reticular fibrosis, whereas in prefibrotic, you may not see it, or it could be grade 1 or less. As well as in overt myelofibrosis, you see a leukoerythroblastorosis picture. There's also secondary myelofibrosis that's post-ET, post-PV. So these patients require a prior diagnosis of ET or PV, and fibrosis more than 2. They have additional features which are common in myelofibrosis, including anemia, leukoerythroblastorosis, splenomegaly, constitutional symptoms, as well as LDH, elevated LDH. Sometimes it could be really difficult to diagnose primary myelofibrosis because it can mimic some of the other conditions. So these are probably good to know some of the common things that can happen. So MDS with fibrosis, I mean, late stage PV, ET, CML, which is currently not have transformed into either secondary myelofibrosis or more advanced stage CML. CMML sometimes can actually look like myelofibrosis with scarring, and occasionally they can have like a low grade driver mutation. There's like entity called autoimmune myelofibrosis where there's no driver mutation. It's basically autoimmune phenomena. These patients also have autoimmune antibodies, hairy cell leukemia, lymphoma, metastatic carcinoma, myeloma, and granulomatous infections. They can occasionally present as more like myelofibrosis and require further diagnostic workup to differentiate between them. If you look in the histology, I mean, on the left side of the panel, you see a characteristic feature that there is a hypercellular marrow. And in these two panels, you see abnormality of megakaryocytes. So they are atypical and they are in clusters. So that's a very typical feature for myelofibrosis, as well as reticulin deposit in the interstitium of the marrow. Here you see the sort of grading of the reticulin fibrosis. So it is less dense here, so MF2, and then here's actually more dense and more extensive as MF3. Sometimes they're also called mild, moderate, or marked on the biopsy report. Here you see the presence of collagen fibrosis. It's shown in the trichome stain. We talked about that one of the key feature in the major criteria is presence of driver mutation. Here in this slide, we see presence of different driver mutation and in different diseases, PV, ET, and primary myelofibrosis. As you know, JAK2 mutation is exclusively present in PV. There may be a very small percentage of patients who don't have this JAK2 mutation. in primary myelofibrosis, majority of the mutation we see is a JAK2, but maybe one third could be KLR, smaller percentage MIPL, MPL, or much less frequent is triple negative. Here on your right side, you can see in the ET, most common is JAK2, then KLR, then MIPL, and then sometimes triple negative. And then driver mutation is important because now we know since 2004 that JAK, since 2005 that the JAK2 mutation, that's V617F, and we know more about the JAK stat signaling. So in normal scenario, you see that the ligand binds to the receptor. JAK is actually not is separate from the cytoplasmic portion of the receptors. However, when the ligand binds to a receptor, it leads to conformational change in the receptor that leads to activation of JAK. And JAK in terms, which are Janus kinase, it phosphorylates itself as well as the receptors. This leads to activation, phosphorylation of the STAT. And the phosphorylated STAT actually leads to activation of various transcription factors. Majority of them have role in proliferation as well as inflammatory cytokine production. This is sort of an extensive list of various cytokines that are dependent on JAK activation. I've highlighted some of them, which are probably key in the myeloproliferative neoplasm. So IL-2, IL-6, IL-11, interferon gamma, GM-CSF, IL-11, EPO, and TPO. You can see these are inflammatory cytokines as well as growth factors for the various myeloid cells, which are characteristic to the two characteristic features, including inflammation as well as myeloproliferation. So I mean, so myeloproliferative neoplasm, including myelofibrosis, is a chronic inflammation-driven sort of a tumor model. There are many cytokines involved in the pathogenesis as well as progression of myeloproliferative neoplasm. Again, the key ones are interferon 1 beta, TNF alpha, IL-6, IL-8, VEGF, PDGF, TGF beta, as well as interferon in progression, as well as origin of the myeloproliferative neoplasm and myelofibrosis. We spoke about driver mutation, but the small percentage of patients may not have driver mutation, or they may have co-mutations. This was the work done by Dr. Venucci in Italy, and then Dr. Tafiri, and they noticed that there's 5 various mutation which actually leads to increased risk for premature death and leukemic proliferation, and these are called now high-risk molecular changes. These are ASXL1, ECH2, SRSF2, U2AF1, and IDH1 and 2 mutation. Presence of one mutation is bad, but sometimes they can have more than one, which actually leads to further reduce overall as well as leukemia-free survival. Dr. Tafiri, as you know, is actually a main guru in the myeloproliferative neoplasm. He has done extensive workup and discoveries. So he also described various cytogenetic changes and their impact on the survival in these patients. So he divided into favorable risk, unfavorable risk, and a very high risk. As you can see, it actually determines the prognosis in terms of survival. Very high risk patients, the median survival only 1.2 years, whereas favorable up to 4.4 years. So this is a slide showing the pathogenesis. So it starts off with the driver mutation that leads to myeloproliferation, as well as cytokine release leads to neogenesis, also stem cell mobilization. This in turn leads to osteosclerosis, stem cell mobilization leads to extramedullary hematopoiesis, scarring of the marrow leads to ineffective hematopoiesis, and then inflammatory cytokine leads to inflammation. And eventually this manifests clinically as splenomegaly, cytopenias, constitutional symptoms, and late complication could be portal hypertension, thromboembolism, as well as infections. So what are the presenting features when these patients usually present first time? About 1/5 of the patient may be asymptomatic, and they may be just discovered incidentally when we are checking their blood counts. They have a peripheral blood smear done for any other reason, or they were examined and they were noticed to have hepatosplenomegaly. The most common symptoms are fatigue, night sweat, and weight loss. Um, Splenomegaly leads to early satiety, abdominal discomfort, and left upper quadrant pain. Some of the sometimes occasionally could be uncommon presentation, could be thrombosis like Budd-Chiari syndrome, extramedullary hematopoiesis. Most common is splenomegaly actually, but it has been described at various places. Lymphadenopathy is relatively actually common, but it has been described in the brain causing intracranial hypertension, or in the vertebral column causing spinal cord compression. But these are sort of the rare manifestations. There are now a few prognostic scoring system for myelofibrosis, and they're divided into generally into low risk, intermediate, or high risk. If you see that the low risk easily have survival a decade or more, whereas high risk is actually talking about less than 2 years. Some of the key points to remember is that, and they're probably shared in all these prognostic scoring system, includes age, constitutional symptom, anemia, leukocytosis, and blast percentage. So these are kind of easily clinically determined, and they can help to determine prognosis for the patient. So depending on if you have these information readily available, you can have a very good idea about the prognosis in this patient. DIPS plus is somewhat more advanced, but because it includes the need for transfusion, platelet count, and unfavorable karyotype, so it actually gives a much cleaner prognosis. Now, with the discovery of various mutation and their impact on survival, we have MIPS, MIP70 plus version 2.0, and GIPS. If you have a karyotype and molecular mutations available, the best one is actually MIP70 version 2.0. All of these, they apply to primary myelofibrosis, mainly not they have not been studied as much in secondary myelofibrosis, but DIPS plus has been studied, and it's quite prognostic in secondary myelofibrosis. But in this patient, MIP70 version 2.0, because of the incorporation of the genetic changes, as well as the cytogenetics, you can see actually you can have a very diverse group starting from very low risk, where actually survival could be in 2 decades or more, versus very high risk, where the survival could be really low, less than 2 years. So MySec PM is the one that's developed for secondary myelofibrosis. There's another prognostic scoring system recently developed, and that actually looks at the response criteria to the ruxolitinib, which is typically the first line treatment, looking into the dosage, the spleen size reduction, need for transfusion, and it determines the prognosis for these patients at 6 months who have been on ruxolitinib. Um, there's another prognostic scoring system. This was developed by the German group, Nico Gegelman, who looks into some of the same but a little bit different variables, and determine the outcome for patients that will be undergoing transplant, to determine their outcomes, and that can be used as well. Okay, so what's the indication for treatment in these patients? Generally speaking, when you see this patient, they're presenting with weight loss, night sweats, fatigue. That is the indication of treatment. Sometimes they present with anemia, and that's the main symptom. That's the indication of treatment. Hepatosplenomegaly, mostly splenomegaly, that's an indication for treatment. Here in US, we have 4 different JAK inhibitors available: so ruxolitinib, fedratinib, pacritinib, momelotinib. They're slightly different. We'll go over that, but they can be used. However, none of the current medical therapy actually provides cure except allogeneic transplant. And so, generally speaking, patients who are not low or very low risk, so if they're intermediate or high risk, they should have HLA typing and donor search considered at the onset of the disease, or later when they're intermediate or high risk disease. In terms of approaches, I mean, it's device. We really look at myelofibrosis, whether it's low risk or high risk, and these are the various scores for low risk, high risk. Low risk would be something very low. It's called low risk. High risk would be something intermediate or higher. For low risk patients, if they're asymptomatic, they could be observed. I mean, these are actually from the NCCN guidelines, and I'm actually part of the panel in the NCCN guidelines. Asymptomatic patient, I mean, we talked about it, low risk, they could have survival up to decade. So they can be observed, or if there are clinical trials available, they can be considered for the clinical trial. For symptomatic patients, I mean, clinical trial can be can be considered, and if not, then usually the first line treatment is the ruxolitinib. Other treatment potentially that can be used is interferon hydroxyurea for cytoreduction. Patient, if they're symptomatic and platelet count is low, pacritinib is actually a better option because it's not as myelosuppressive. And then we continue monitor this patient. If they're responding, you continue treatment. If they are intolerant or no response, you can consider changing it to a different JAK inhibitor, including momelotinib or fedratinib. If there's a disease progression, high risk, we will go over the slide for that, or accelerated phase, we'll go over that as well. For higher risk patients, you look at the blood count, symptoms, spleen size, um, then it breaks down into if patients have low platelets or not. If they have low platelets, I mean, these patients, they don't tend to do too well, and so transplant should be considered. If they're not candidate, then pacritinib is the one which is less myelosuppressive, or momelotinib if the platelet count is more than 25. For patients who have a platelet more than 50, and I mean, again, their high risk, transplant should be considered. If they are not candidate or not immediately they want to, I mean, depends on their presenting symptoms, whether they have splenomegaly or constitutional symptoms. Check it. Ruxolitinib still category 1, as well as fedratinib, but then, I mean, momelotinib or pacritinib can also be considered in these patients, or can be switched, for example, if they're not responding or they're progressing. Um, Anemia is a big problem in these patients. These patients sometimes are requiring frequent transfusion. This could be from various reasons, disease progression. A common thing to check in these patients is actually make sure they're not deficient in any nutrition factors, like they could have a subclinical bleeding, so check for nutritional deficiency, iron, B12, folic acid. These patients are actually quite malnourished because of the splenomegaly. They may not be eating and drinking, so they could very well be nutritional deficient. Hemolysis is common. Sometimes you'll see these patients having a PNH concurrent with that. So that should be ruled out, because treatment of PNH can actually help to mitigate the anemia. So really, in these patients, if they have if they have anemia, we look into several other things. If they have splenomegaly, constitutional symptom of momelotinib is probably better option, or there would be pacritinib or ruxolitinib with an add-on agent to help with the anemia, like luspatercept, erythrocyte stimulating agent, or danazol. If they have no splenomegaly or constitutional symptom, again, if they have there's an option of a clinical trial that can be considered, or one of these anemia targeting medication can be considered. Momelotinib actually can be considered. We used to use lenalidomide and prednisone. It's not used as much, but they still can be used for patients who have 5q deletion. If patient have both splenomegaly as well as constitutional symptoms, a JAK inhibitor with combination with any of these anemia targeting medication can be considered. Or as we will see later, that use of pacritinib or momelotinib is actually also helpful in these patients to mitigate the anemia. Sometimes these patients over time can progress into the accelerated or blast phase. Um, Accelerated phase, something when the blast percentage in the blood or bone marrow is 10 to 19%. If it is more than 20%, that is considered the blast phase, or if they have a myeloid sarcoma. I mean, these patients should be definitely be considered for transplant, because their outcome is, especially blast phase, it's their really poor, and I mean median survival is less than 6 months. Since the majority of these patients are older, so they're not usually candidate for intensive induction. Occasionally they are. So most of the time we're using HMA plus venetoclax or HMA plus JAK inhibitor. I should mention, and you'll see in the slide later, this occasion actually accelerated phase. Sometime if you have a donor ready, you can take them directly to transplant, and their outcome is actually pretty good without prior need for any treatment. I mean, very quickly, I mean, there are 4 drugs approved, but I'll go over ruxolitinib, which is the oldest drug. This was approved in 2011 based on the trials we call Comfort 1 and Comfort 2. Comfort 1 was done in US, Canada, and Australia, and Comfort 2 was mainly done in European countries. So in Comfort 1, patient who had intermediate 2 or high risk myelofibrosis, they was randomized 1-to-1 with ruxolitinib versus placebo. And they looked at the primary endpoint, which is spleen volume reduction, 35% or more at week 24. Similarly, they looked at improvement in the symptoms, which we use these MPN symptom assessment form at 24 weeks, as well as the overall survival at 144 weeks. I mean, here we have the baseline characteristic, quite similar. They had both primary and secondary myelofibrosis, intermediate and high risk disease. Here's the breakdown for the blood counts as well as the spleen size. You see here the spleen volume, that's actually quite a lot, like a median spleen volume of about 2.6 liters. Normally, spleen volume should be less 500 cc or less. So this patient have a quite big spleen. On the right side, you see the primary and the secondary endpoint. You can see that about 42% of the patient has spleen volume reduction, 35% or more. Here's the waterfall plot. Majority of the patient on ruxolitinib had a response. Below this line, you see that 35% or more reduction. Similarly, you see that the improvement in the symptoms was much better. That was studied through the total symptom score, through MP and SAF survey, that compared to the placebo. So patient did much better, and all the symptoms in various, like including abdominal discomfort, pain under the ribs, early satiety, night sweat, itching, inactivity, and bone pain, they all actually got better compared to the placebo. This was the trial mainly done in European countries. They actually did a randomized trial, slightly different, 2-to-1 ratio, and they compared with the best available therapy. Primary endpoint was the same as spleen volume reduction from baseline to week, however, 48, and they looked at the survival. Um, Quite similar results. You see spleen response is about 28% in this one compared to 42% that was seen. And you see a waterfall plot here that, I mean, majority of the patient had a spleen volume response. Similarly, you see it here as well. Here in this table, you can see all 4 different JAK inhibitors that are available: ruxolitinib, fedratinib, pacritinib, and momelotinib. They are actually somewhat different in terms of some might target JAK2 more than JAK1. For example, fedratinib and pacritinib, as well as pacritinib and momelotinib, it targets ACVR1, which actually helps with the anemia in these patients. Here's the FDA approved indication, usually intermediate or high risk, and the dosages. Here's the breakdown of the what was the spleen volume reduction. Majority of them about 30 to low 40%, and some of the adverse effects, they're similar, like anemia. However, there are somewhat different as well. For example, Jakafi can cause withdrawal syndrome if you stop it, because it has a short half-life compared to some of the others, and also because it also blocks the JAK1, which usually controls most of the inflammatory cytokines. Fedratinib, one thing to remember, GI symptoms and Wernicke's encephalopathy, so you have to check the thiamine level. before starting and monitor it. And patient better to be on thiamine so they don't get this encephalopathy. Pacritinib usually can cause some GI side effects. I mean, in the beginning they were trying it and there was some cardiac toxicity, so they put a hold on it. But subsequently it was removed because there was also some excessive bleeding. Momelotinib, I mean, uh, so GI toxicity can happen, nausea can happen. Also, sometimes creatinine rise can happen, so that should be monitored in these patients. The question comes that these JAK inhibitor, do they affect the survival of these patients? So there was a very interesting retrospective study done by Lucia Masarova in MD Anderson, and what the group compared was they looked at the survival of the patient from 2000 to 2010 versus 2011 to 2020. This was because in 2011 ruxolitinib got approved and some of the other JAK inhibitor were coming also. What they saw that in the pre and post JAK inhibitor introduction era, there was improvement in overall survival from 48 to 63 months. And this was seen both in the lower risk as well as the high risk group. So you can see, for example, in high risk, the median survival improved from 30 months to 45 months. So JAK inhibitors generally improve the survival, and there are other studies in the follow-up of the comfort study also showed that. We spoke about the JAK inhibitor. There are several other targets that are currently being looked at in the myelofibrosis, either as monotherapy or combination therapy. Tagrexafab, which is a CD123 diphtheria toxin approved for the treatment of BPDCN, it's currently being looked at as combo treatment. Navitoclax actually was it's a BCL2 BCL-XL inhibitor by AbbVie. It was studied. However, I think a company has dropped the development of this drug. Parsaclisib was another one for PI3 kinase inhibitor, and this was mainly to look at the AKT pathway. And again, this was also not moving forward by the company. MDM2 inhibitors, selinexor, imetelstat, bomedemstat, and pelabresib, these are actually actively being looked at. Their phase 3 trials going on. And the phase 1, phase 2 look promising for these combination. Probably the one of the most exciting treatment that's coming is targeting CALR mutation, because CALR is actually bound on the outside of the MPL receptor, so it can be targeted by various immunotherapies. So they're looking at developing antibody. In fact, there's a naked antibody functional trial going on right now by Insight. We're looking at CALR targeting antibody, which is ongoing at the moment, phase 1 trial for both ET and myelofibrosis. Similarly, a group has in Australia has developed a CAR T cell, and they also look at vaccine against the KLR, both ET and myelofibrosis. So what happens if patients on treatment, and when do we call them JAK inhibitor refractory? There could be different patterns of failure. They could have a suboptimal response. They could have loss of response. They can have worsening cytopenias or leukocytosis. They could transform into blast phase. They could have secondary cancers, as we sometimes see with the ruxolitinib patient developing skin cancer, which are really refractory to treatment or developing infectious complication. And I mean, and when these refractory patients come, they can be sometimes really hard to manage. So for option could be clinical trial. Sometimes the response progression could be subtle, so they may be able to continue treatment for short term. These patients should be strongly considered for transplant. Sometimes they can be changed to a different JAK inhibitor, like a patient who are progressing or ruxolitinib. Sometimes you can recapture the response by using fedratinib. If it's only anemia, luspatercept can be considered. Sometimes you see that these patients have refractory splenomegaly. So in these patients, actually, splenectomy can be a therapeutic option as well for management. And I'll talk about more about transplant. That's my passion for these patients. So allogeneic transplant is the only curative treatment. However, it's associated with transplant-related morbidity and mortality due to graft versus host disease. Infection, there's a risk of graft rejection due to fibrosis of the marrow and splenomegaly, as well as other regimen-related toxicity. The question always comes that when to do it, what regimen to use, and does the JAK inhibitor have any impact on the outcomes? So, I think most of the experts would say that, and some of the studies that doing it for patients whose survival is less than 5 years, but any of the prognostic criteria is definitely recommended. There has not been like prospective studies looking at reduced intensity conditioning or myeloablative conditioning, which are big enough to show the difference. But we are learning more that reduced intensity conditioning with the current regimens is actually probably better and safer because of less transplant-related mortality in these patients. However, younger patient can still get away with the good outcomes with myeloablative conditioning. GVHD prophylaxis is not well established for one reason is that all the institutes are using different GVHD prophylaxis. We are seeing more and more use of PTCY in the US. Our center usually uses uh, tacrolimus and sirolimus based regimen. What we know is that additional JAK inhibitor can actually help improve the GRIFs, which is a composite endpoint in transplant. And then even pre-transplant use of JAK inhibitor can be helpful in improving transplant outcomes. Transplant was actually performed very early when the transplant was be used for acute leukemia. This is a report from our institution, City of Hope, reported in 1982. And they're showing histological changes that happen. For example, on the top panel, you see hypercellularity and atypical megakaryocyte. On the bottom, you see the right aquiline fibrosis. And you see the histology become more and more normal with normal cellular marrow. You don't see the clustering of megakaryocyte. And at the bottom, you see the patient at 1 year does not even have a reticular fibrosis, so that has resolved. So transplant, you pick up a conditioning regimen. The role is actually to cytoreduce the malignant clone. This allows for the graft versus leukemia effect from the donor immune system to take over. And then, we talked about regimen could be myeloablative or reduced intensity conditioning. And we talked, and the choice of conditioning again depend on the age, performance status, and the comorbid condition. I've listed here various studies that were done to look at the transplant outcomes in myelofibrosis in chronological order, just to show you that with time, like from 80s to like late 2010s, you see that we are doing transplant in older population, as well as you see that with time there's an improvement of the overall survival and reduction in the non-relapse mortality. This is because we have JAK inhibitor, we have improved supportive care for these patients. We understand it better. We have reduced intensity conditioning, and we have PTCY, although it may be a little bit later, but we also have PTCY, which could be beneficial in patients who who may not be able to tolerate other GVHD prophylaxis. Also to know that, previous studies were using more myeloablative, and more recent studies have been reporting more reduced intensity conditioning, we're still reporting really good outcomes in these patients. Also, the various prognostic scoring systems are being looked at, and they can be predictive of the outcomes. Scott et al. From Fred Hedge reported use of DIPS. Bano et al. Reported DIPS plus. Our group reported actually MIF70 and MIF70 plus and how it impacted the outcomes. And then Nico Gigelman from Germany reported the prognostic scoring system that they have developed in predicting outcomes in these patients. If you look at the trend for the last 2 decades, you do see the number of transplant in chronic leukemias, both MDS and MPN, is actually going up because we are doing much better with the transplant with the new reduced intensity conditioning and the supportive care as well as the PTCY. Um, the question comes also in transplant, which donor is better? I think majority of the studies have shown that the HLA identical donors outcomes are much better than compared to match unrelated and definitely mismatch donor. Here on the right side, this is a study published by our group, and it shows that for example, for match sibling at 5 years, the survival is really good, 75% compared to mismatch unrelated, which is actually quite low, about 29%. I should mention here that when we published this data, PTCY was not very commonly used. So a lot of these patients did have complication from graft versus host disease. Now we're using alternative donor like haploidentical transplant, and that's actually looking very good as well. This is a survival reported by a group here in US showing overall survival at about 3 years, about 75%, which is really good, and with the low grade 3 4 acute GVHD as well as low extensive chronic GVHD. Splenomegaly is quite a unique feature of myelofibrosis, and so splenomegaly does impact the outcome in these patients. And the EBMT group looked at the effect of splenomegaly. They noticed patients who have progressive splenomegaly going into transplant, or patients who have a spleen size on manual examination more than 15 centimeter. They had increased peri-transplant morbidity and mortality. So sometime, especially for patients who have massive spleen, which is refractory, we do recommend splenectomy before undergoing transplant in these patients. How does the ruxolitinib impact the transplant outcome? We know that patients who are undergoing transplant on ruxolitinib, they're responding, their outcome is actually really good. And these are the patients that are represented in this blue line here. Their outcome is 90% or more. Patient who have progressed through leukemia, they have the worst prognosis. Patient who have stable disease or maybe progression or blast percentage, they have prognosis is much lower. So therefore, the timing of transplant is really important in the patient. If you have it on ruxolitinib, they are intermediate high risk, and you have a good donor, you should proceed to transplant because these patients have really good prognosis if you have a good donor and you're able to proceed. Um, our group, as well as a German group, looked at the use of peri-transplant use of ruxolitinib, and it showed that it's safe and feasible. On top of that, it actually prevents graft versus host disease. It may even help with the engraftment by reducing the inflammatory cytokines and improving the splenomegaly. So in our group, we use it from day -2 of transplant, and we use it as long as we can continue, but definitely try to use it beyond day plus 30. So you're over that acute phase where the GVHD may happen. So it's been shown now that it's safe and tolerable. It does not impact the graft function or does not cause graft failure. It decreases the peri-inflammatory cytokine that may help into improvement of the graft function. And it actually prevents withdrawal syndrome. In the beginning, there was a lot of patients who were on ruxolitinib, and ruxolitinib was suddenly held, and these patients were developing withdrawal syndrome, which is more like a cytokine release syndrome. But using it peri-transplant really ensures that these patients don't get into this cytokine release syndrome. It definitely reduces GVHD, as all of you know that ruxolitinib is approved for treatment of both acute as well as chronic GVHD. This is a slide showing a comparison of when I was mentioning that accelerated phase transplant, if you have a donor, you can proceed to transplant and their outcome is as good as chronic phase. This is using reduced intensity conditioning. You can see both the blue curve showing the chronic phase and the red curve showing accelerated phase, that the outcomes are actually quite similar. So these patients with 19% or less blast in the blood or bone marrow can be proceed to transplant with really good outcomes. This is another study. It was done through CIBMTR collaboration. They had non-transplant and transplant patient, and they looked at dips, both low risk, intermediate, or intermediate higher, in risk, and looked at the differences in the outcomes. What's very interesting, you will see that if you look at all group, you do see actually transplant is actually has a better long-term outcome compared to the non-transplant outcome. In low risk group, I mean, for many years actually, before the transplant, yes, I mean, non-transplant outcome is better, mainly because I mean these patients they live long term in decades. Um, Here in the intermediate one, you see actually interesting phenomena of this survival curve actually crossing each other. So what's showing that maybe in the early part, non-transplant is an option, is has better survival, but in long term, actually, even for intermediate one with disease, transplant has a better outcome. So in conclusion, this is my final slide. I'll say that the JAK inhibitor are the mainstay of treatment that are currently being used for myelofibrosis. Uh, if your patient has a donor and transplant remains the only curative option that should be considered in patients with intermediate or high risk disease, these patients should undergo HLA typing if you think these patients could be transplant candidate. One thing to note is that sometimes these patients may not look like candidate, but you put them on ruxin inhibitor, they gain weight, the phenotype, and they look like a completely different person. So then transplant can become candidate, can become option for these patients. Now we're doing increasing number of transplant due to thankfully to improvement in the transplant survival, as I showed you in that table, mainly because of the use of reduced intensity conditioning, better supportive care. We have better HLA typing and matching and the registries that we can find a donor. We use the peri-transplant option for ruxolitinib. PTCY is being used in alternative donors. Alternative donors, including mismatch, partially match, or haploidentical, are being used, and that have really translated into improved outcome of transplant of these patients. And really, I mean, we need to develop new and improve pre-transplant treatment because they are shown to improve the transplant outcome in patients who are responding and can overall improve the survival in these patients even without transplant. Thank you very much.
Great presentation, Dr. Ali.
Thank you, Dr. Shah. Any questions?
There's a
I see
question
a
in chat
question.
box.
Right, I see. Dr. Rafiq Ahmed have a question. Can you please tell about what age will be the best for transplant in myelofibrosis patient? I mean, if you're looking at the kind of the older age, I mean, really, here we have done transplant in patients who have really excellent performance status in mid and late 70s. And in these patients, we typically, I mean, we use the non myeloablative or reduced intensity conditioning. And I mean, we actually have a system of patients who are 75 and older. They go through this extensive vetting process through high risk transplant committee before transplant is approved. But we have done it. I mean, I personally have done it in an 80-year-old gentleman who actually was on the trial, did really well, and then he's post-transplant now 6 months. So yes, I mean, in mid 70s, maybe late 70s, an excellent candidate. You can consider transplant because these patients otherwise have a really poor outcome. Um, Prospective data of on overall survival with ruxolitinib. I mean, Comfort 1 and Comfort 2, they have long-term follow-up and they compared these patients and they did show actually in these prospective trials that patient did have better outcome with the ruxolitinib. I mean, so ruxolitinib does improve the overall survival based on this Comfort 1 and Comfort 2 data.
There are some questions in Q&A box. Can you please check?
Q&A. In the webinar chat?
In the Q&A one, I can ask you. So, Dr. Mary Indani Khan is asking, what's your opinion about pre-transplant splenectomy in MF?
So we do it actually in patients who have progressive splenomegaly and their spleen size is 20 centimeter or more on examination. European data was more use of 15 centimeter or more, but we use it 20 centimeter or more based on the fact that we use a melphalan-based regimen like fludarabine and melphalan is actually much more myeloablative and it's better in controlling the spleen size. So yes, I mean, but that's probably only 10-15% of the patient. Our practice is mostly we start patient ruxolitinib when they're responding, and then we proceed with the then we proceed with the transplant if they're responding because the data is showing in responding patient the transplant outcome is really good.
And there's another question. What are the major challenges in terms of side effects and patient beliefs when starting these therapies?
Yes, I mean, yeah, challenges, like with patients are usually part of these big advocates, like patient groups, and they learn about other patient experiences, good or bad, and they come up with a preconceived sometimes notion that this may not be the best treatment because this patient had a side effect or that patient had a really bad side effect of transplant. I mean, I see in my practice, I spend a lot more time talking to the patient because these patients, they have chronic diseases. They sometimes still think that they can live longer without transplant or different treatment. So, I mean, really have to spend a lot of time with the patient and just win their trust and present the data. And I mean, then they make decision based on their preferences.
There's another question. Could you comment on the use of raloxifenib early after LOHCT start day dose adjustment and for how long?
I mean, so we for with the fully meshed donors, not in the PTCY setting. So we start at day -2, 10 milligram twice a day, and we continue it through the transplant. And if the patient is not having any issues with the graft function, we continue it. My practice is to continue it up till day 100 if I can, but at times they do get into trouble with the blood counts recovery. So then actually we slowly taper it off. So then we don't get into trouble of patient requiring frequent transfusion. So from the 10 milligram twice a day, starting those down to maybe 5 milligram twice a day, and then gradually taper it off in a week or two. So, but try to at least 30 days up to 100 days. I mean, the more you can use it, the better because you get overcome that period of acute GVHD, which could be really detrimental in these patients.
And there's one more question. Ruxolitinib advantage is seen regardless of JAK2 status or differently?
Very good question. JAK2 definitely better, maybe a MPL mutation. Ruxolitinib in CALR can be actually somewhat difficult to give because these patients are very sensitive and they get cytopenic. So especially type 1 CALR mutation patient, they do get quite cytopenia. So dosing has to be done very gradually and maybe better to even start on a kind of a lower dose because these patients are really sensitive to ruxolitinib. So yeah, so I mean in these patients, you can use it, but it have to be lower dose. In these patients, actually, pacritinib might be a little bit better because it is more for these myelodepletive myelofibrosis, and it doesn't cause as much cytopenias.
Thank you so much, Dr. Ali. It was
Okay.
pleasure hosting you.
Thank you, Dr. Shah, and thank you everyone for attending. Assalamu alaikum.